Hello and welcome to Learning EMG. In this video series, we're going to review the clinical and electrodiagnostic features of the most common neuromuscular disorders. If you find our channel informative and helpful, please do subscribe and do not forget to hit the bell icon to be the first to watch our videos. In this video, we will review Myotonic Dystrophy Type 1. Let's dive in. Myotonic disorders are a heterogeneous group of inherited muscle diseases characterized by the presence of clinical and/or electrophysiological myotonia. Myotonia is the inability of a muscle to relax instantly after a voluntary contraction. Clinically, myotonia appears as a delayed muscle relaxation after a voluntary muscle contraction or after a direct muscle percussion. Electrophysiologically, myotonic discharges are manifest by repetitive, abnormal, spontaneous discharges of the muscle fibers with waxing and waning of frequency and amplitude with a firing rate between 20 to 80 Hz and the characteristic dive bomber sound. It is important to note that the myotonic discharges are not always equal to myotonic disorders, as these discharges can be found on other conditions such as inflammatory myopathies, hypothyroidism, and drug-induced myopathies. Although there are several types of myotonic myopathies, in this video we will focus on clinical and electrophysiological features of myotonic dystrophy type 1 as a frequent type of myotonic myopathy. Dystrophy myotonia type 1 or DM1 is an autosomal dominant muscular dystrophy caused by expansion of the CTG trinucleotide repeats in the DMPK gene on chromosome 19. Genetic anticipation is a prominent feature of DM1. Progressively more severe symptoms are seen in successive generations due to increasingly large CTG repeats expansion during germline transmission. The clinical onset of DM1 is variable, and the age of onset is most often inversely proportional to the length of CTG repeat. DM1 typically presents with a characteristic clinical picture consisting of frontal balding, mild ptosis, wasting of the facial and masseter and temporalis muscles, early cataracts, and distal muscle weakness with associated clinical and electrophysiological myotonia. Atrophy and weakness of the facial muscles gives rise to a characteristic appearance that is called hatchet face appearance. Patients usually describe myotonia as an impaired and delayed relaxation of muscles after a voluntary muscle contraction, such as hand grip. This is called action myotonia. On the other hand, you have a percussion myotonia. Percussion myotonia is that percussion of the thenar eminence results in prolonged involuntary opposition of the thought that is called percussion myotonia. An interesting phenomenon in patients with DM1 is that myotonia usually decreases with repetitive muscle contractions. This is called warm-up phenomenon. Extramuscular manifestations include cardiac diseases such as conduction defects and cardiomyopathy, early cataracts, gastrointestinal symptoms, and mild cognitive impairment. In some cases, endocrinopathies in forms of insulin resistance and hypogonadism may be seen. Deep tendon reflexes are reduced to absent, but sensation is always normal. Serum CPK is mild to moderately elevated. Now, we're going to review the electrodiagnostic findings. First, with respect to sensory nerve conduction studies. As the sensory system is spared in these patients, sensory potentials are normal in amplitude, latency, and velocity. With respect to motor nerve conduction studies, motor nerve conduction studies are usually normal, but can show mild reduction in the CMAP amplitudes of the distal muscles in patients with DM1, especially those with severe diseases. Motor latencies and conduction velocities are within normal limits. With respect to the repetitive nerve stimulation test or RNS, RNS at 10 Hz produces a decremental pattern in patients with DM1. Short exercise test. If you perform short exercise test for 5 to 10 seconds in these patients, This test will produce a drop in the Cmax amplitude immediately after the exercise. This is then followed by prompt recovery within about 2 minutes. If the test is repeated, the Cmax amplitude drop is not reproducible. This is known as habituation. With respect to the needle EMG findings, myotonic discharges are electrophysiologic hallmark of DM1. Myotonic discharges are repetitive discharges with a rate of 20 to 80 Hz and the characteristic waxing and waning of the amplitude and frequency. They produce a distinctive direct bumper sound. Myotonic discharges are most prominent in distal limb muscles, particularly in pan-intrinsic muscles, muscles of the forearm, particularly forearm extensors, ankle dorsiflexors, for example, the tibialis anterior, and facial muscles. Occasionally, they can be found on proximal muscles. Other spontaneous activities include positive sharp waves, fibrillation potentials, and complex repetitive discharges. EMG on voluntary contraction usually shows a myopathic EMG pattern with low amplitude, polyphasic, and short duration MUPs with early recruitment. This pattern is most frequent and more prominent in the distal limb muscles and follows the same distribution as the muscle weakness. Okay, in this video, we review the clinical and electrophysiological features of myotonic dystrophy type 1. In this pocketbook entitled Summary of Electrodiagnostic Medicine, we have gathered the clinical and electrophysiological features of the most common neuromuscular disorders. This book is available on Amazon website. You can hit the link below in the description to see the book page on Amazon website. Hope to see you soon with another summary video. Take care and goodbye.